Clinical chemistry, lipid and lipoprotein disorders. Women have on average a higher HDL cholesterol, but lower total cholesterol and triglyceride levels than men. After menopause, there is no difference in total cholesterol. Total and LDL cholesterol and triglyceride levels all increase with age in both men and women. Total cholesterol, LDL cholesterol, and triglycerides are much lower in young children than in adults. At puberty, boys' HDL cholesterol drops 20% to adult male levels, but girls' does not change. There's also a lower rate of LDL cholesterol and heart disease in Asian populations. Dyslipidemia is an elevation of plasma cholesterol and/or triglycerides or high LDL. It can lead to the development of atherosclerosis. There are primary and secondary dyslipidemias. Primary include an increased production of lipoproteins, abnormal intravascular processing, or defective cellular uptake of lipoproteins. Familial hypercholesterolemia is one disorder to make note of, and that's a defect in the LDL receptor, where LDL levels remain high and they continue to rise throughout the lifetime of the individual. Secondary causes include diet, so increased cholesterol would be high saturated fats and cholesterol. Increased triglyceride would be alcohol excess or alcoholism or excess caloric intake. Drugs like anabolic steroids, beta blockers, those would increase cholesterol, or estrogens and thiazide diuretics would increase triglycerides. Metabolic disorders such as diabetes, hypothyroidism, or pregnancy, or diseases. So increased cholesterol would be a hepatoma or multiple myeloma. Increased triglyceride would be nephrotic syndrome or renal failure. Hyperlipoproteinemia are diseases that are associated with elevated lipoprotein levels. Includes hypercholesterolemia, hypertriglyceridemia, and combined hyperlipidemia. All of these words are really long, but if you break them down into their stems, it'll make them a little bit easier to understand. Hyperlipoprotein. Hyper means too much. Lipoprotein is talking about a lipoprotein. When we break down hypercholesterolemia, hyper means too much, cholesterol means cholesterol. Same thing with hypertriglyceridemia. Hyper, too much, triglyceride is talking about triglycerides. And hyperlipidemia is just too much fats in general. Atherosclerosis is the thickening of the artery walls due to aging, single leading cause of death and disability in the United States. It's caused by lipids in the form of esterified cholesterol being deposited in the artery walls, resulting in fatty streaks. Fatty streaks develop into plaques that can block blood flow. Atherosclerosis is a specific kind of arteriosclerosis. The lesions start as fatty streaks. They progress to fibrous plaques that partially occlude the vessel. Disruption of the plaque promotes the formation of occlusive thrombus, leading to acute myocardial infarction, AMI, or a heart attack, a stroke, gangrene, or aneurysm. Is associated with dyslipoproteinemias. Hypercholesterolemia is a lipid abnormality most closely linked to heart disease. Familial hypercholesterolemia, FH, is a genetic abnormality predisposing people to elevated cholesterol levels. Hypertriglyceridemia, elevated triglyceride levels, so high 200 to 500 mg per deciliter, very high would be greater than 500 mg per deciliter. It's due to either genetic abnormalities or hormonal abnormalities. Combined hyperlipoproteinemia, elevated levels of serum total cholesterol and triglycerides, increased risk for coronary heart disease or CHD. Genetic forms, there's familial CH and familial dysbeta-lipoproteinemia, which is very rare. There's also an LPA elevation, which increased risk of CHD and cerebral vascular disease. Hypolipoproteinemia is low levels of lipoproteins. So hypo means less. Lipoprotein is talking about lipoproteins. Hypoalpha lipoproteinemia, isolated decrease in circulating HDL concentration is less than 40 mg per deciliter without the presence of hypertriglyceridemia. Alpha denotes the region in which HDL migrates on agarose electrophoresis. It's associated with several defects, often genetic, most of which are linked to increased risk of premature CHD. We can look at a blood sample, and just by looking at it, we can determine some indications. So if there's a creamy layer on top, that's typically due to increased chylomicrons. If it's lipemic, so the serum looks, or the plasma looks turbid or milky, we have an increased VLDL or IDL. If there's no turbidity but it's slightly orange in color, we have an increased LDL. If it's normal and clear, we have increased HDL. Lipid measurements. So lipids and lipoproteins are important measures of CHD risk. There's standardized decision cut points for CHD risk developed by NCP. Cholesterol measurement, hexane extraction after hydrolysis with alcoholic potassium hydroxide, followed by reaction with Lieberman-Burchard color reagent. The current reference method for is GC mass spec. Triglyceride measurement is useful in detecting metabolic disorders and CVD risk. High CV percent, the reference method is GC mass spec. Lipoprotein methods, so measure physical properties like the density, size, charge, apolipoprotein. Methods include ultracentrifugation, electrophoretic separation, chemical precipitation, chromatographic, and immunochemical. HDL methods. In the past, there's a two-step separation by chemical precipitation. Now there's a three-step process: ultracentrifugation to remove VLDL, heparin manganese precipitation to remove LDL, and analysis of supernatant cholesterol by Abel-Kendall assay. LDL methods include beta quantification and the Friedewald calculation. Beta quantification is the most common. It combines ultracentrifugation and chemical precipitation. The Friedewald calculation bypasses centrifugation, and it's commonly used in routine and sometimes research labs. They're compact analyzers, mobile point-of-care testing systems that can measure cholesterol, triglycerides, HDL cholesterol, and glucose from a fingerstick sample. So beta quantification is a measure of HDL-C on separate aliquot of plasma by standard methods. Alternatively, measure HDL-C in a sample. You want to treat to remove ApoB100 containing lipoproteins and determine HDL-C on cleared supernatant. Then you're going to calculate VLDL and LDL. So these are the formulas for doing those calculations below. LDL cholesterol is usually measured indirectly via calculation, or the Friedewald equation. Most widely used method to determine LDL-C. You want to measure total cholesterol, triglycerides, and HDL-C, and then you can calculate LDL-C using this equation below, or the Friedewald equation. So total cholesterol minus HDL cholesterol minus triglycerides divided by 5. All concentrations are in mg per deciliter. You should not use this equation when triglycerides exceed 400 mg per deciliter. Samples with significant amounts of chylomicrons or non-fasting specimens you should also not use, or patients with type 3 hyperproteinemia. VLDL composition is abnormal. Triglyceride divided by 5 does not apply in those situations. So this is a chart that's used in the diagnosis of lipid and lipoprotein values. So step 1 would be looking at total cholesterol, fasting or non-fasting. Then you're going to look at the fasting lipid profile, so total cholesterol, total triglycerides, and then HDL cholesterol. You're going to do the calculations to find the HDL ratio and LDL cholesterol. And then step 3 is ultracentrifugation for VLDL cholesterol, LDL cholesterol, and HDL cholesterol. And the equation for the Friedewald formula is listed below. Again, this formula is not valid if triglycerides are over 400. Apolipoprotein methods. ApoB is measured directly by immunoassay. ApoA1 is measured by separation and analysis of HDL cholesterol, and LPA is commonly measured by immunoassays. Phospholipid measurement can be measured by an enzymatic reaction sequence, and fatty acid measurement is commonly analyzed by gas liquid chromatography. Precision, so changes in diet, exercise, weight, smoking, clinical conditions, disease, medications, conditions, and blood testing can alter measurements. Accuracy, it's ensured by demonstrating traceability or agreement through calibration to respective gold standard reference system. Matrix interactions. In the past, analyte matrix interaction problems occurred on process reference materials, so the CDC created certification programs to ensure accuracy. Analytic performance goals established by NCEP lab panels based on clinical needs. For total cholesterol, performance goal for total error is 8.9%. Quality control. Commercial control materials may not approximate patients' specimens. Control materials prepared in-house from freshly collected patients' serum are preferable. The specimen collection, EDTA, is the primary anticoagulant, and it requires correction by a factor of 1.03. So the classification of the risk for CHD, total cholesterol would be less than 200. If it's greater than 200, then we have a higher risk. LDL, we're looking for it to be less than 130. HDL, we're looking for it to be greater than 40. If it's greater than 60, then it's actually protective, but we want that number to be greater than 40. And then triglycerides, normal would be less than 150.